What's going on, everybody? Welcome to episode 165 of the Core Consult RX podcast. Cole, AJ, what's going on, gentlemen?
Doing great. 165. That's a nice number.
It is a nice number. We're getting pretty close to 200.
We are.
Pretty excited.
Yes.
So, we're looking back and, kind of seeing what some of the topics we've covered. And this is one I feel like we've at least mentioned or something, maybe, but I know it looks like we haven't done an episode in a while.
Well, there's been some significant changes too.
Yeah. So we're gonna
pretty much redoing. I mean, pretty much if we talked about it before, this is
the redo.
It was very simple, and now it's simple in a totally different way.
Yeah, there you go. That's a good way of putting it. But should we call them new? They've been published, I think, since online at least since June.
We're still in 2021, so we'll call them new.
Newish.
Yes.
Newish C. diff.
They'll be new to a lot of people, I think.
So, yeah, we're going to kind of go through some of the changes. Not a lot of changes, more just kind of like updates. There's three big ones that they've kind of added or changed around a little bit, but we'll kind of go through the whole topic, a little bit in general, and then we'll talk more specifically about where some of these recommendations came from. So hopefully this will be a little bit of a review. But C. diff.
Yes.
Where do you want to start?
Clostridium difficile. Is that how you say it?
Yeah, I think so.
I guess so, right. I didn't realize that they actually identified it relatively recently. It was in 1978. Mm-hmm. They knew that people had a lot of antibiotic-associated diarrhea and colitis, but it wasn't until then they actually identified that it was C. diff. In a lot of the early cases, they attributed to Clindamycin, which we know is a big culprit.
And that was a box warning. On Clindamycin specifically. I don't think they've added that to the other, statistically more likely culprits nowadays, but I think Clindamycin is the one that started us off.
Yeah.
It's because of we're not using Clindamycin nearly as often anymore. Fluoroquinolones and then some of the penicillin cephalosporins have actually started to be more likely candidates of what's causing and leading to the C. diff infections nowadays. But that doesn't mean that clindamycin's out of the woods. It's just we don't really use it that much.
It's just not used as much.
Yeah.
Right? It's used a fair amount in kids, it seems, right?
Yeah.
Maybe not more than adults, I would think.
And I guess if you need an MRSA coverage for an oral option, outpatient, something.
I've definitely felt like it was an adult and it was just a huge amount of clindamycin. A huge amount of clindamycin for them to finish the course because I guess they needed something, probably liquid or whatever. They maybe had trouble with tablets, and it was just so many bottles of clindamycin to mix.
This is going to be disgusting.
Yes, and it does not taste good. But C. diff is usually associated with being a hospital-acquired infection. We're all pretty familiar with the protocols that might need to be taken if a patient is diagnosed with C. diff, but it spreads a lot in the hospital. It can be contracted in the community, and that would be a patient who has C. diff and had not been hospitalized during the 12 weeks prior to diagnosis. So it'd really be a bummer to get 11 weeks out from the hospital and then get C. diff, and now that's nosocomial, but it's usually in the hospital, and we also can have recurrent infections as well after they've had it, and we'll talk through both of those.
And then just to throw this out there too, this has been knowledge here for a while, but I don't think we mentioned this at all in the last time we kind of covered C. diff, but there was some surveillance that was kind of monitoring C. diff infections from 2003 to 2006, and they started noticing more like frequent, severe, and refractory infections that were standard refractory to standard therapy and more likely to relapse than they had kind of seen previously. And they started seeing this throughout North America and Europe as well. And so they have like this new strain, if you will, that they have a few different kind of nicknames or abbreviations for. One is abbreviated as BI, one is NAP1, and then one is ribotype 027. Basically, these names are all describing the exact same strain. It's just that based on the different methods that were used to kind of like type those strains, that's where the different names come from. So now it's kind of like one of those things where if you see the proper terminology, because there's three different nicknames for it, if you will, you'll see NAP1 /BI/027, and that's supposed to be indicative of that specific more virulent strain of C. diff. And the thought process is because this strain is attributed with more toxin production compared with some of the original strains that were being studied. They kind of noticed that the emergence of this seems to be correlated with the more prevalent use of fluoroquinolones. And then you start seeing this fluoroquinolone resistance, outbreaks, strains that starts happening. And then, they sort of kind of found out that it seemed to be in comparison to the rise in this virulent strain of C. diff as well. There's also another version called ribotype 078 that was first talked about in the Netherlands, and its severity is pretty similar to the 027. It just seems to be more prevalent in like younger patient populations, and there's some other studies that have kind of looked at that, but it's interesting to see, like, even something like this, you see like this resistance and these mutations. And if you look on UpToDate, they have a really good kind of breakdown of some of the genetic factors that have changed. And you'll see that a couple different loci or genes moving just a slightly bit, and the whole kind of resistance pattern or mechanism of the pathogen changes. It's pretty crazy.
It is crazy. Ribotype 027 sounds like some sort of undercover spy robot or something like that.
It definitely does.
Definitely could be, right?
It could be. You never know.
So one of the kind of the bad years for C. diff was 2011. There was an estimated 453,000 initial cases of C. diff infection in the U.S. Also an estimated 83,000 of first recurrences of C. diff infection, with almost 30,000 deaths, which was a lot for 1 year. But between the following 6 years, there was actually a decline in the incidence of C. diff infections, primarily because of a decrease in overall healthcare-associated infections, kind of as we became more aware and cautious, I suppose, right?
So in order, for people getting C. diff, it's basically, an environmental contamination from whether it's, lowering the patient's, natural, micro organisms that lay in the GI tract. That's in a lot of times that's where we typically kind of think about C. diff infections occurring as patients who have had a recent exposure to antibiotics and things. But you also will see a lot of patients that, especially in the outpatient setting, a community setting, where they'll get infected with C. diff, and there's not really any history of antibiotic use or anything like that. And it could be literally as simple as just coming in contact with contaminated food or something along those lines. But it is transferred via, wait for it, fecal to oral route, everyone's favorite. And that's every time I see that, I'm just like, oh man, not good.
Is that what you think?
That's what I think every time. Because I'm 12 years old.
You retch every time you see fecal to oral route.
It's disgusting. But, the fecal to oral route, ingestion of the spores. And so, from that, they, in their spore form, if you will, they're not necessarily like activated, but once they get ingested and are able to kind of start to colonize in the GI tract, that's when they, start to become not only active, but also start producing toxins, but also become potentially susceptible to antibiotics and whatnot.
Yeah, and we'll talk about it later, but there can be a fair amount of people who are a reservoir. They have C. diff, they could culture for it, but aren't having symptoms. They don't necessarily need treatment. But we'll talk about that. There are some risk factors for more severe infection, people getting C. diff and also having a more severe infection. So age over 65 is definitely one. Patients who are on chemo, obese, if they had some sort of GI surgery, if they have IBD, cirrhosis, and then possibly gastric acid suppression. So we've heard about the big push to get patients off of prophylaxis for the ulcers in the hospital, because it's kind of on an order set that's generally used for a lot of people, and not everybody needs it, and they think that the PPIs may be related to an increased risk for C. diff, and that's kind of where that comes from.
It's funny because I've heard from a few different people now that whenever we talk about the potential for increased risk of C. diff infection with like long-term, especially long-term PPI use, or just gastric acid suppression in general. I've heard a few people say, my doctor said the only people that ever worry about that are pharmacists. I was like, hey, that's not nice.
That is one of those classic things that a pharmacist does, which I guess we talked about this on our last episode a little bit, but one of those classic things a pharmacist does on the team is like get them off the PPI if they don't need it.
Yeah. They do say that the data that, kind of looks at this association, it's not super clear as far as, how they correlate and, the duration of PPI use versus the infection risk and all that stuff. So basically what the authors from UpToDate and some other sources will basically say that if the patient's on a PPI unnecessarily, it makes sense to probably discontinue just to be on the safe side, but until they have like true sufficient evidence to show that it's not harmful or is harmful, there's not like a clear cut recommendation. So if a patient has some sort of issue where they really do need to be on a PPI, it doesn't mean you have to stop the agent. So just kind of keep that in mind. You want to talk a little bit about the toxins, I guess, before we jump into some of this?
Yeah, go for it.
So when we think about the exotoxins that kind of lead to the potential colitis and then diarrhea, they have toxin A and toxin B, and then without going into too much detail, basically toxin B seems to be, by some standards, about 10 times more potent than toxin A when you're looking at, kind of like its ability to cause that colon mucosal damage. And so there are situations where the strain that the patient's infected with will have toxin B only, and they will still basically be just as virulent in regards to how sick they get, because toxin B is the one that seems to have the most weight. And then there are cases where, like Cole was saying, where they may not have either toxins or non-toxigenic, and they're not producing those toxins, whether it's in vivo or in vitro. And that's where it's, that we don't really consider it pathogenic at that point. But when we get to the toxins production, when one of our new adjunct therapies is kind of targeting specifically that side of things, so figured I'd at least throw that in there to mention it. What do you want to go from here, Cole?
So kind of merging into patients with C. diff, there's some general things to keep in mind. So the infection control precautions are a big one. So if a patient is suspected or proven to have C. diff, they should be placed on contact precautions. Healthcare workers should wash their hands before and after patient contact. Hand hygiene is very important, specifically with soap and water. They think that's more effective than the alcohol-based hand sanitizers in removing the C. diff spores, since a lot of them are resistant to killing by alcohol, which is really unfortunate because what is the most common thing that the healthcare workers do when they leave a patient room? It's stick their hand under the alcohol-based hand sanitizer before they go into the next room. So just another example of how C. diff is sinister, for lack of a better word. Soap and water is favored. Another thing that I guess you don't usually think about is, of course, we have antibiotic culprits that frequently lead to C. diff. So an important initial step before thinking about treatment is to discontinue the antibiotic that is inciting the C. diff infection as soon as possible. So just some examples of some antibiotics. We mentioned clindamycin and fluoroquinolones, also broad-spectrum penicillins in combination, certain cephalosporins like second, third, and fourth generation, and also carbapenems are frequently associated with the C. diff infection. There's some others that are less commonly associated, but you can still see it. Macrolides, Bactrim, first-generation cephalosporins, sulfonamides, but those are some of your primary ones. You want to stop it, that antibiotic, unless they need the antibiotic. It's more important to have that to treat the primary infection. If that's the case, then just try to be prudent with which antibiotic you're selecting and see if we can use an alternative that might not be as significant towards the risk factors for C. diff. The last thing kind of initially is checking their fluid, nutritional, and diarrhea status. So they very well may need supportive care for these from fluid loss and electrolyte imbalances, because diarrhea is unfortunately the hallmark. Very smelly diarrhea, so I hear. Haven't experienced it myself. But very smelly diarrhea is definitely a hallmark of C. diff, and so fluid loss and electrolyte imbalance can definitely be common.
Yeah, my first day in the surgical and trauma ICU when I was on rotation there, the preceptor was telling me that um, they had this patient with, we brought up something about C. diff, and he said, yeah, I had the worst case ever, the other day, and he started telling me a little bit about it, and basically he was telling me that he saw some of the cleanup crew, if you will, in hazmat suits and like mops and stuff, just kind of in there slipping and sliding, sloshing around, and I was like, awesome.
I imagine
I can't wait to go back to outpatient.
What is the Monsters Inc? It's the 3319 or something like that when they toss them all in the showers and shave them down and wash them with the hazmat suits. That's what I imagine with C. diff.
Dude, if that's the actual like code that it's in Monsters Inc., I'm gonna be very,
3319.
very impressed.
I don't think that's the exact one, but it is something 19. 23. Okay, I'm being told by AJ it's 2319.
2319.
I was very close.
That's impressive. We'll chalk that up to you having a son now. That's why you know all about Monsters Inc.
No, he's not old enough for Monsters Inc. yet. But
He's plenty old enough to watch cartoons.
I meant to mention that the anti-motility agents that you usually think of with diarrhea, like loperamide or Lomotil, they're generally or traditionally, I guess, avoided. There's some evidence that they cause harm, but that's kind of controversial. So in general, we would reserve these for patients who are having difficulty keeping up with the fluid loss. And so you're not just going to give everybody loperamide with C. diff because that has been associated with some potential harm.
Yeah, I think that's definitely more important too when you think about like outpatient or community pharmacy rather. When they have patients coming in because they don't want to go to a provider's office or urgent care or something, and they're like, "Hey, I'm gonna take this, loperamide. Is that cool?" That's where in that particular setting, without any other context or information or any ability to test anything, it's probably a good idea to tell them to stay away from.
And then they poop their pants while they're talking to you, and it's like, yeah, maybe you might need to get checked out.
And you offer them Gatorade or Pedialyte and just say, listen, replenish those electrolytes, my man.
Exactly.
No, but that's definitely a go, because I feel like that's something that gets asked a lot in that particular setting.
Yes.
So patient comes in and, we saying, okay, C. diff infection, where are we going to kind of classify that as whether it's mild, severe kind of thing. The first thing we kind of want to look at is whether or not their white blood cell count is less than 1,500 or above that. That's one of the markers for how we can kind of classify severe disease versus non-severe, as well as serum creatinine. If it's less than 1.5, then that's also considered non-severe. So white blood cell count less than 15,000. Did I say 1,500 the first time? I may have. Less than 15,000, and the serum creatinine less than 1.5. That means non-severe. If the patient has a white blood cell count above 15,000 and their serum creatinine is 1.5 or higher, that's going to be considered severe. And then we also have fulminant colitis or fulminant C. diff, which is basically like a more severe and complicated form of C. diff, if you will. And that's where you're getting more of like this systemic toxicity that is happening alongside the overall GI issues. So patients that have hypotension or even shock, if there is ileus, presence of ileus or megacolon, that's also indicative of fulminant colitis. I don't think that there's like a completely like agreed upon calculation for severity score, but the non-severe and severe non-fulminant is kind of agreed upon, but then after that it's a little bit up in the air.
Well, even within those specific like white blood cell count numbers and serum creatinine, it's not like it's evidence based. That's more of a consensus.
Mm-hmm.
So if they're below, like they don't meet those parameters, but you feel strongly that it's a severe situation, then you can make a clinical decision and say, I'm going to classify this person as severe. So there's definitely some wiggle room. It's not like those aren't necessarily hard numbers or anything.
Yeah. And then as far as like, the actual treatment decision, obviously once you've kind of done your initial assessment, ultimately it is left up to the clinician's judgment and, looking at certain things that could be a potential risk factor for, more severe cases. So like Cole mentioned earlier, patients that are a little bit older, so 65 years of age and older tends to be a risk, as well as some of the other things that he had already mentioned. Those need to be taken into consideration as well when you're starting, especially initial therapy. They've never been treated before, and that's really where a lot of the big changes that are starting to happen.
Right. And before we talk about the drugs, there is like, who do we treat? So treatment would be warranted for a patient who's had acute diarrhea, so greater than 3 loose stools in the last 24 hours without another explanation for that, and then a positive laboratory assay for C. diff, because like we said before, you can be colonized with C. diff and not have symptoms and not necessarily need treatment. Empiric treatment before getting the assay can be initiated in certain cases. Really, if you have a very high clinical suspicion that they have C. diff, based on their severity and the results of the assay are still pending, but you want to get them started on treatment, you can definitely make that call if you have a strong suspicion for that. But not indicated in patients with a positive assay who don't have diarrhea or other C. diff manifestations, because it is common to be an asymptomatic carrier.
So, treatment options. And this has changed so many times, I feel like.
It sure has.
Not like huge changes where it's like they start adding in all these different crazy drugs.
Just
but
like a swapping of the same things.
Yeah, that's exactly what it feels like. Because I know we learned it one way when I was in school. I don't know I guess with you,
we were in the oral
probably
bank.
in the middle,
oral bank for
the
me.
first switch.
Yeah.
And so for a while, which is really funny because I literally just did a review of my PA students that are about to graduate on Saturday to get them ready for the PANCE exam. And I mentioned the antibiotic that we're going to talk about today. And
Don't
I was
spoil it yet, right?
Yeah. And I need to leave you hanging there. And I was like, this is one you may or may not see. And then I got, we started talking about this episode and I was like, oh man.
Yeah.
So there you go.
Yep.
So cliffhanger for you. But so before oral vanc was that's really the only time we'd ever see oral vanc because usually vanc is no absorption from the small intestine and whatnot, so it just kind of all gets accumulated in the colon. That's why we have to give it IV typically. But
on the opposite way, the IV vanc won't really give
anything.
Good exposure in the colon, so that's why you can't even use IV vanc there. That has to be oral.
And so it's one of those things that that was kind of the main treatment for a while. And that's what I kind of thought of. And it used to be a thing where that was really expensive, and it was hard to get access to. And then it became generic, and they started having compounding formulations available, and it was just like, all right, we're in business. Now we might not be in business anymore. Yeah. Because
it's not like it doesn't work or anything. It's
that's true.
It's not. It would not be a wrong option,
right?
I would say.
Yeah, no, that's a good point.
Yeah,
but the new guideline updates, basically the first recommendation of the 3 main changes are that when it comes to like the initial treatment of a patient who's never had anything or any treatment options for C. diff, it's their first episode. Basically, what they are now recommending is that patients get the difficile or fidaxomicin is recommended over vancomycin now. So, wah wah.
Yeah.
So fidaxomicin, if you're not familiar with it, it's under the brand name difficile. It's the only only treatment like indicated, or it's the only disease state indicated for that treatment, hence the name. And it's one of those things that like it's an antibiotic that a lot of us probably haven't even seen before,
right?
Because it's the cost is pretty preposterous, and but it seems to be, based on some of the new studies coming out, it does seem to be a little bit more effective, especially when it comes to like the relapse rates of the patient who is treated initially, and then how likely are they to have a reoccurrence. That's what we can kind of see with some of the new studies, is that the actual cure rates initially seem to be the same, but the patients who are on fidaxomicin over vancomycin do tend to have a little bit less likely chance of having a recurrent episode.
And I think that's an important point. So this is based on the new IDSA, SHEA, IDSA and SHEA guidelines. And it really is, I mean, they don't, it's a weak recommendation. Like the level of evidence they put behind it is not the strongest, but they still felt it was strong enough to say we're going to recommend this over that. But like Mike said, you're still going to get the same cure rate with oral vanc that you would with difficile. You just might prevent recurrence, is what the studies are showing. You're not going to necessarily reduce mortality. We don't have that kind of data. Reduce recurrence. So to that point, if it's going to be more expensive than oral vanc, just right now it is. So if cost is an issue, the people we want to kind of target for using difficile over oral vanc in those cases, if access or cost is an issue, would be the high risk patients. So the ones over 65, the ones with compromised immunity, severe C. diff, the robot. SPY, the ribotype 027. So the people who fall into that classification, we want to do everything we can to prevent recurrence because they're going to be a higher risk for having poor outcomes. But in general, if you don't have good access to it, oral vanc is still, like we said, not wrong. Just they are preferring vancomycin.
Yeah, and dosing wise, the preferred dosing recommendations is the vancomycin 200 milligrams twice a day for 10 days. There was one study, however, that used like what they call pulse therapy, basically, and they did initially they did the 200 milligrams twice a day, and then after the initial I gotta get the right thing. I had it right in front of me, and then I switched my screens. But basically, they continued once daily after that for an extended period of time, up to I think it was the 20-day mark. I gotta find this so I can actually say the correct thing. But the extended pulsed regimen is what they refer to it as, and that was compared directly to vancomycin. So it was 200 milligrams twice a day for days 1 through 5, and then once daily on alternate days on days 7 through 25. So I'm glad I found that. Going off of my
That's odd.
This is like one of the studies that they used. It doesn't. The actual name of the study was the Extend trial, and that was looking at the vancomycin directly compared to vancomycin in patients that were 60 years of age and older, and that was in Lancet Infectious Disease in 2018. So that was the regimen they happened to use in that particular case. And there's kind of some discrepancy as far as like the patient way that they reported kind of the outcomes and things like that. But the standard dosing for vancomycin is still twice a day for 10 days.
And the twice a day is nice. I mean, the oral vanc is 4 times a day for 10 days. And I can tell you that 4 times a day dosing is a pain in the behind. Yeah.
And hard to keep up with.
High risk for non-adherence too. So I think that's good. There's a backup option, an alternative that is generally considered less effective, which is the Flagyl. Was Flagyl recommended? Is that what you were referencing? Like when you were coming
I was in school,
through?
Yeah.
Okay, so that was first line then.
For like the non-complicated and less non-severe, I should say. It was kind of like metronidazole is probably a good option, and then if they have a recurrent one, then go vanc.
Don't you love how you have to relearn things? So it's only been a short amount of time since you've been out of school, a relatively short. I mean, imagine,
because I'm so young.
Imagine how often things will change over the course of our career. Isn't that crazy?
I know.
That's why you got to listen to podcasts and stay up to date.
Literally, the only thing you need to do is listen to podcasts and you'll be fine.
Got to do it. Metronidazole is generally considered less effective for the treatment of non-severe, but it would really only be if oral vanc or vancomycin is not available or unaffordable or certain or that sort of thing. But generally avoided in patients who are frail, or if they're over 65, or if they develop C. diff in association with IBD. You want to avoid it. But like Mike said, the 10-day thing is important. That's the recommendation for the non-severe duration. There are instances where it might need to be for longer. So in the setting of another underlying infection requiring prolonged duration of their antibiotic. So if you're treating a primary infection, and they have to stay on that antibiotic, but they also have C. diff. In this case, we might prolong the treatment of the C. diff course. So the recommendation for this is to treat the C. diff throughout the antibiotic course, plus an additional tail of 1 week after the completion of the antibiotic course. So I think that's an important thing to mention. Just because somebody has C. diff doesn't mean they're only going to get it for 10 days. If they're continuing a primary infection antibiotic, they need to have it for potentially a fair amount longer.
And also too, like if you look at the American College of Gastroenterology guidelines for treating C. diff, when they talk about their initial episode of non-severe C. diff, they have the vancomycin 4 times daily for 10 days as they're a strong recommendation based on low quality of evidence. And then you look at the fidaxomicin 200 milligrams twice a day for 10 days as a strong recommendation with moderate quality of evidence. So even they are kind of mentioning that. So it's kind of interesting. But the big pushback is going to be the cost of fidaxomicin. So it is, I think the AWP is still like upwards of the high 3,000 mark for a 20-day supply or a 10-day supply. So not going to be a
Which
great
I remember
option.
the Vanc cost. I mean, it was probably like, I would have to look at it. I could spitball, but it's still like not like $5. It's going to be like a couple hundred. But obviously, with insurance, as long as they cover it, it doesn't matter. But
and I think some of the other generic formulations, like the first compounded solution, some of the other ones they had, I think that one was fairly cost effective.
Yeah.
But it definitely was. I mean, I remember being like an intern and stuff where the oral Vanc was still really pricey.
Right.
But fidaxomicin being brand name only is still very expensive. That being said, if you have a patient who has commercial insurance and you do want to kind of follow the newest guidelines, then if you check out merckconnect.com/difficile, there is patient assistance and copay assistance on there. And basically, you can get the copay down to $50 if the patient has commercial insurance. Now, if you have TRICARE or Medicare, Medicaid, or the self-pay, obviously that's not going to be very helpful. But
the copay card wouldn't be helpful, but they usually have a different program, which would probably be a time inhibitive process where you would apply to have it for free from the manufacturer. But considering this needs to be treated quickly, it probably wouldn't be a reasonable option.
Yeah, but it is available. I mean, there's definitely options out there. So make sure you look through those if you need to go that route. Because I think the card covers up to it's $3,400 per prescription that they'll pay for.
Nice.
So yeah.
Another kind of reason that fidaxomicin is now considered first line, not just because of the risk of recurrence, but its effect on the microbiome, right? So that's obviously a big concern with antimicrobial resistance and that sort of thing. So far, it seems that there's a minimal alteration of the microbiome with fidaxomicin. It's not used very often. The risk of bowel colonization with Vanc-resistant enterococci associated with Vanc and flagell use is comparably much higher than with fidaxomicin. So I think that's another reason why they are kind of favoring it.
Yeah, it's definitely a good point. So yeah, that's the big initial treatment recommendation change that we saw. The other kind of thing that we need to look at now is potential adjunctive treatment options that we have, specifically when we are thinking about our recurrence of C. diff. So with the first C. diff recurrence, they still kind of have the same recommendations, and that's where they actually mention the fidaxomicin 200 twice daily for 10 days, or doing it twice daily for 5, followed by once every other day for 20 days. So not quite the same that was used in that one study, but that's another like pulse regimen that they offer in the guidelines themselves. And then same with vancomycin, they have a tapered or pulsed regimen that you can do for that one as well. An example of that with vancomycin would be like doing 125 milligrams 4 times daily for 10 to 14 days, and then 2 times daily for 7 days, once daily for 7 days, and then every 2 to 3 days for 2 to 8 weeks. That's a lot, but it's an example regimen that they do have in there, but they still have the preferred regimen is fidaxomicin, even if it's the first recurrent episode. And then they say that we should also be looking at adding bezlotuximab, 10 milligrams per kilogram, which is given intravenously, and then that's given along with the administration of standard of care antibiotics.
Yeah, I think this is a pretty cool drug. A few years old now, but it's a monoclonal antibody that binds to the C. diff toxin B, targets that. So just another example of how monoclonal antibodies are taking over the world.
Yep.
But yeah, I think it's a cool little drug.
And the concern, I think, from the not concern, but the thing that the guidelines do mention is, it's something that a lot of times you have to go to an infusion because it's IV, so you have to go to an infusion site to get this. And so the logistics of not only getting, the medication, prescribed and then having to go actually get it administered and infused can be a little cumbersome. And then, the insurance carriers are really going to be wanting this to be coming from an infectious disease specialist or a gastroenterologist. And a lot of times C. diff can be treated by, whether it's a hospitalist or a primary care, provider or something. And so getting this covered is going to be another tricky kind of thing to navigate. And so that's something that you probably is going to take a while before we start seeing more patients being actually given this, but it's something that they do recommend now based on the studies and showing that you can reduce the recurrence, the recurrent rates in the future once this patient is given this on top of their standard of care antibiotics.
Yep. So definitely an option for recurrence. One that I always like to mention is the fecal transplant, right? I always think that's super interesting, but it's like a totally real thing, which just sounds so crazy. But for patients who have a third or subsequent C. diff infection recurrence, so they have to have at least 3 episodes, so an additional episode plus 2 recurrences, who present with a 4th or further. A good option can be the fecal transplant. So what is this thing? So this is how I know we've talked about C. diff before, because I remember talking about this a long time ago.
You said something about a poo shake, I believe.
I did talk about the poop shake, which is a thing, but that's a little bit different. That's kind of to colonize their microbiome a little bit. So this is not a poop shake. It should be administered via a colonoscope because a larger volume of stool can be instilled in the colon. But they do have an oral capsule version, but it's not as recommended because you'd have to take a whole bunch of capsules. But basically, they're taking a donor's stool and instilling it into the colon with a colonoscope and colonizing their microbiome with different flora that'll hopefully, out colonize the C. diff, because that's part of the big reason C. diff happens. You have an antibiotic, it wipes out your intestinal flora, C. diff takes over, and now we have an infection. So we can just replace it with another person's poo.
And then problem solved.
I love it. You get paid? No way. $40 per stool? You're literally pooping gold. Oh my goodness.
Oh my gosh, it's a whole new world.
It's a whole new world.
For all you students listening that really need some extra coin.
Yeah, forget about donating plasma.
Yeah.
You're regular.
Yep.
You don't have IBD or something. Not that I'm sure there's some microflora.
Maybe you have a better production.
Maybe you have a better production. Yeah. I mean, go for it, dude.
Yeah, I think secretly Cole's going to sign.
I don't think I'd be a good donor. I have a history. I don't know. I don't think I'd be a good option.
I feel like we're getting to know you on a whole different level now.
I don't think I'd want to curse somebody with my bowels. You know what I mean? But I mean, if I knew that somebody had really good bowels and I was having trouble,
be like, hey man,
let's just swap.
Can you?
So the alternative to that would be a colectomy or be a surgery to have a portion removed. So in many cases, at least up to date, favors the fecal transplant over that, but the surgery is another option.
And so, those are the 3 main kind of changes that we see. And when it comes to like fulminant C. diff infection, they still do recommend vancomycin 500 milligrams 4 times a day, whether it's either mouth or nasogastric tube. And then if there's there's ileus, then you want to consider adding a rectal instillation of vancomycin instead. But it's one of those things that, and they do mention you could also potentially consider metronidazole IV as well, along with oral or rectal vancomycin if ileus is present, to make sure that you actually can get the antibiotic to the site of action.
Right.
But
ileus being a bowel obstruction, which is really just like a loss of muscle tone in a certain portion of the colon that obstructs.
Absolutely. And so it's not a ton of changes, but it is interesting that now they've moved fidaxomicin up. I was not expecting that one, but
no, I wasn't. I have seen it dispensed once.
I've seen it on the shelf of a pharmacy one time. That's about it.
I did see it dispensed once. I think it'd probably be remiss if we didn't mention probiotics, which come up a lot with the C. diff conversation. The verdict may still be out, but at this point, not enough evidence to support the use of probiotics for C. diff prevention. Probiotics can reduce general hospital-associated diarrhea a little bit. I think there's some reasonable evidence for that by reducing it by a day kind of thing if a patient is taking an antibiotic. But to actually prevent C. diff doesn't seem like there's evidence for that.
Yeah. But yeah, so make sure you check out the guidelines. It's the Infectious Disease Society of America. Like I said, it was first published in June online, and I think officially in print in September, I believe. But yeah, those again, just to kind of recap, the 3 changes is the pushing up of fidaxomicin is the preferred option for the not only the initial infection but also recurrent episodes as well. Fidaxomicin is the preferred over vancomycin, and then patients that have a potential for their first standard, or not standard, but the first recurrent episode, they do say to add on bezlotuximab as an adjunct therapy as well. So there you go. Anything else?
That's all I got.
Cool. So there you go. There's your update, guys, and then we'll hopefully touch on this topic again in 2 more years when there's a new
when
guideline.
they change it.
When
Yeah,
they change it
they'll
back
change
to
it back to
metronidazole.
Flagyl.
Yeah, metronidazole will be the go-to again. We'll just replay our old episodes. But yeah, so thank you guys so much for listening. Hope that was helpful. If you have any questions for us, the emails will be in the show notes, and you can also reach us on any of the social media platforms. And also don't forget, if you want to text clinical questions or anything like that directly, you can reach us at 415-943-6116. And yeah, we've been getting some good clinical case type questions on there. It's been kind of cool. I don't know if it could be students cheating on ClinApps or something like that and getting me to answer their stuff for them. I don't know, but I've gotten some good stuff from alleged pharmacists that have been pretty interesting. So appreciate those questions and stuff. It keeps us on our toes too. But yeah, thank you guys so much for the support, and we'll catch you next time. Have a great one.